Well, hi, everybody. Welcome. We are so glad to have you with us tonight. My name is Charlene Margot, and I am co-founder of nonprofit The Parent Venture. We are honored and delighted to have with us tonight Dr. Rex Huang, who will be talking to you about Breaking the Silence, a doctor's insights on youth suicide awareness and prevention. Please join me, everybody, in a really warm welcome for Dr. Huang. Take it away, Rex.
Great. Thank you so much, Charlene.
Thank you. That's your cue.
All right. Thanks so much. Hi, I'm Dr. Rex Huang, child and adolescent psychiatrist, chief of psychiatry at Kaiser Permanente Redwood City Medical Center. I've been with the organization now for actually almost 14 years now. But September happens to be Suicide Prevention Month, and I'm truly appreciative of your joining in today to learn more about youth suicide. Um, it's a serious public health issue that affects individuals, families, and communities. And while it may be an uncomfortable topic for some, the attention and awareness for prevention, intervention, and resources can have the ability to save lives. First of all, this is a slide that indicates that I have no relevant disclosures. I'd like to cover quite a few topics today. First, we will raise awareness of youth suicide by sharing statistics and trends to contextualize the urgency. I'd like to then educate everyone on the risk factors and warning signs for suicide in youth, and how it's typically not always just one thing we point to as the root cause. Next, I'd like to debunk myths and misconceptions about youth suicide. For example, talking about suicide does not increase or cause suicide. Suicide often occurs in the context of mental health conditions such as depression, anxiety, trauma, or substance use disorders. But it can also be influenced by social, environmental, and biological factors too. There's not just one root cause of it all. I'd like to empower parents in being more comfortable on how to talk to your child or adolescent about suicide and provide guidance on immediate steps should they endorse thoughts, intentions, or a plan. And finally, I'd like to give community perspectives and resources. It takes a village, and what healthcare organizations are working towards, such as the zero suicide model. I'll give some pertinent resources as well, and happy to answer your questions too. So why is this relevant? Suicide among young people continues to be a serious problem in the United States. Over 49,000 suicides occurred in 2023, with suicide being the second leading cause of death among children, adolescents, and young adults ages 10 to 24 years old. Um, Males are 4 times more likely to die, although females tend to make more attempts. Another sobering statistic: the 2019 CDC death reports reveal that every day, approximately 18 youth die by suicide. This has sparked a declaration of a national state of emergency in children's mental health by the American Academy of Pediatrics, American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association. During the COVID-19 pandemic, ED visits for suicide attempts increased, especially among adolescent girls, including in the Bay Area. The highest prevalence of suicidal thinking is seen in females, American Indians, and LGBTQ youth. However, according to the CDC, 1 in 5 high school students seriously considered attempting suicide in 2023. And research using data on preteens for rates of death by suicide in children ages 8 to 12 rose 8.2% annually from 2008 to 2022. Specifically in San Mateo County, 2011 to 2020 numbers show the suicide rate as 1.6 deaths per 100,000 in 0 to 19-year-olds and 8.3 deaths per 100,000 in 20 to 39-year-olds. And while rates in 2021 and 2022 were relatively low numbers, That does not mean youth are immune from risk here. So what puts youth at risk for suicide? The most common link is pre-existing mental health conditions, especially depression, which has the strongest association. In fact, studies show that up to 90% of youth who die by suicide have a mental health or addictive disorder. Yet only 1 in 5 youth with serious mental illness receive treatment. Other high-risk conditions include bipolar disorder, psychosis, conduct disorders, substance use, and trauma-related disorders. Non-suicidal self-injury and a family history of suicide also increased risk. We'll talk more about self-injury later. Um, Interestingly, suicidality rates can be as high as 42% in youth with intellectual disabilities as well. Beyond clinical factors, there are relational and societal risks too. These include access to lethal means, family history of suicide, bullying and social isolation, family or peer conflict, barriers to mental health care, stigma around seeking help, and marginalization due to race, gender identity, or socioeconomic status. One of the most concerning facts: youth who have attempted suicide are 8 times more likely to attempt again. And 1/3 of suicide deaths are not the person's first attempt. And then the risk of dying by suicide is over 100 times higher in the first year after an attempt. That's why the warning signs must be taken seriously, which I'll go over in the next slide. But early intervention, compassionate support, and informed awareness can save lives. Nearly every young person who attempts or dies by suicide shows warning signs through words, behaviors, or changes in mood. These signs should never be ignored. While not every youth at risk will show these signs, and not every youth who shows them is suicidal, being aware can save lives. Verbal cues may include statements like, "I wish I were dead," or "You won't have to worry about me much longer," or "I hate my life," or "I'm going to kill myself." But suicidal threats are also not always verbal. Behavioral signs can be just as important. These include searching online for ways to die or acquiring means, sudden mood shifts, especially from deep sadness to calmness, withdrawal from friends, families, or activities of interest, um, changes in sleep, eating, or daily hygiene, um, increased substance use or physical complaints, and finally, giving away prized possessions or no longer talking about the future. Parents, teachers, and peers should always err on the side of caution. If a child or teen expresses suicidal thoughts or shows concerning behaviors, they should be evaluated immediately by a qualified mental health professional. I mentioned a couple slides ago that I would go over self-injurious behaviors. Um, Adolescents who have experienced self-injurious thoughts or behaviors are at a higher risk for suicide. One form of self-injury, known as non-suicidal self-injury, or NSSI, involves deliberately harming the body, such as cutting, burning, or scratching, without the intent to die. For parents, witnessing self-injury can be deeply distressing. It's natural to worry that these behaviors mean a child is suicidal. Um, and while self-injury and suicidal behaviors, like imagining, planning, or attempting suicide, can look similar, they're not the same. The key difference in self-injury and suicidal behaviors lies in intent. Self-injury is almost always used as a way to feel better, not to end one's life. In fact, some individuals say it helps them avoid suicide, even though that's not a good strategy. Self-related behaviors, on the other hand, are driven by the desire to end emotional pain or life itself. And there's other important distinctions. Self-injury typically affects only the surface of the body, most likely. Suicide attempts involve more lethal means. Self-injury rarely requires medical treatment, while suicide attempts often do. Self-injury may occur regularly as a way to cope with stress. Suicide-related behaviors are less frequent, but more serious. And self-injury often brings short-term relief or a sense of release. Suicide attempts do not. Still, about 65% of youth who self-injure will experience suicidal thoughts at some point. Many use self-injury alongside other unhealthy coping strategies, such as substance use. One critical concern is that self-injury can lower the barrier to suicide. Repeatedly harming the body may make it easier to act on suicidal thoughts later. Several factors increase the risk of moving from self-injury to suicide. Those include ongoing family conflict or poor parent-child relationships, more than 20 lifetime incidents of self-injury, recent psychological distress, history of emotional or sexual trauma, feelings of hopelessness or self-hatred, a high impulsivity and risky behaviors, substance use, diagnoses like major depression or PTSD. These risks may appear alone or in combination, but the more present, the greater the likelihood for suicidal thinking. But here's the hopeful part. One of the strongest protective factors in a sense is a sense of connectedness to parents. Feeling understood, supported, emotionally close to a caregiver can make a profound difference. Let's start with a common myth. We can't do anything about suicide in our youth. That's simply not true. There are known risk factors and warning signs, as I mentioned in earlier slides. With better awareness, we can take meaningful action at home, in schools, across communities, and within healthcare systems. Together, we can work toward a zero suicide model. I'll share more about that of what healthcare organizations are doing to support this goal in future slides. Another myth, talking about suicide will lead to suicide. In fact, asking direct questions like, are you feeling sad or depressed? Are you thinking about hurting yourself? Or have you ever thought about suicide? These questions can be life-saving. These questions don't plant ideas. They show care and open the door for honest conversation. You're not normalizing suicide. You're normalizing mental health screening and making it okay to talk about emotional pain. Now, how do we start a conversation? First, we want to create a safe place to have the conversation without distractions. It's not about having all the answers. It's about sitting with them in their pain, coming to the conversation in a calm, non-reactive, active listening approach, which is crucial. Now, parents are natural problem solvers and troubleshooters, likely through survival, but the first step is asking directly and having the door open to conversation. If a child doesn't open up, always reassure that you can be a source of support without any judgment. If a child or adolescent says yes, think about how you would talk to your child about other health conditions. How long have you been feeling this way? What happened before you felt this way? Don't try to fix or problem solve at that moment. Try to understand. It helps to praise the child for opening up. You could say, I'm so glad you told me that you're having suicidal thoughts, or I appreciate your bravery in telling me this. Don't minimize what they're saying or feeling. Saying things like, but you have so much to live for, or is this how you want to treat me? These things will probably make things worse. No passive aggressive guilt trips are needed here. it's better to seek understanding. Lean in. What's going on that makes you feel this way? I'd really like to understand more. Or I hope you can continue um, talking to me about your suicidal thoughts. This is really important. And finally, the myth. The reason for suicide is fill in the blank. It might not just be one thing, not just a breakup, a bad grade, or mental illness. Um, Suicide can be multifactorial, often involving a complex mix of emotional, psychological, and situational challenges. Oversimplifying the cause can create blind spots and hinder effective support. By challenging these myths and using compassionate, informed language, we can better protect and support our youth. The way we talk about suicide matters. Words can either reinforce stigma or promote healing. For example, saying someone committed suicide implies wrongdoing, like committing a crime. Instead, we should say died by suicide or suicide death, just as we would say died of cancer. Terms like successful suicide or an unsuccessful attempt are also harmful. They suggest achievement when in reality, these are tragic outcomes. Um, and referring to someone as a suicide reduces a person to an act, stripping away their humanity. We must also avoid framing suicide as a selfish choice. People who die by suicide often believe they're relieving their loved ones of a burden. Their thinking is deeply distorted by emotional pain, depression, or another mental health condition. Um, in these moments, rational decision making is impaired, and the idea of choice becomes misleading. To change the culture around mental health, we really need safe, compassionate messaging. Schools, workplaces, faith communities, healthcare systems, they all play a role. And instead of using fear or graphic details, we should focus on hope, strength, and healing. Our messaging should be engaging, informative, and offer clear steps people can take to seek help. And that's why media coverage also matters. And the American Foundation of Suicide Prevention and others have adopted ethical reporting standards that avoid sensationalism and includes resources for help. The message has to be clear that suicide is preventable and help is available. If you see news articles, that's usually always in the last bit of an article message. Let's talk about protective factors, the things that can help reduce the risk of youth suicide. As I said before, one of the most powerful protective factors is strong family relationships. A sense of connectedness between parents and children, built on trust, warmth, and open communication, can make a huge difference. Parental involvement and appropriate supervision are also key. But remember, every child is different. Some may need more space, while others thrive with close guidance. It's not about being hands-off or a helicopter parent. It's about showing consistent, positive interest in your child's life. That's the foundation for meaningful dialogue and emotional safety. Connectedness to school and community is another major protective factor. When youth have supportive peer relationships, trusted adults even outside the home, and opportunities to engage in positive environments like sports teams, youth groups, music groups, clubs, faith communities, they're more likely to feel a sense of belonging and purpose. In schools, we're seeing promising developments in peer-supported mental health programs. Wellness centers are expanding, and community spaces like Alcove in San Mateo and Palo Alto locations offer peer-led support groups that promote healthy norms, encouraging open conversations about mental health, and showing teens that it's okay to ask for help. And on a broader scale, advocacy efforts have led to increased access to care. For example, Santa Clara Valley Medical Center is building a new 400 million plus behavioral health facility, the first Santa Clara County operated inpatient center specifically for children and adolescents. This is a major step forward in making sure youth have access to the care they need when they need it. And so together, these protective factors, family, school, community, and access to care, they all form a safety net that can truly save lives. Um, Now I'm excited to share that as part of Kaiser Permanente, we happen to be a national leader in suicide prevention, embracing the Zero Suicide Framework. This is a bold approach that treats suicide as a preventable never event within a comprehensive healthcare system. This commitment is backed by research showcasing Kaiser's evidence-based system-wide strategy to improve patient safety. Since 2014, Kaiser Permanente has been integrating zero suicide principles across its care settings. The framework is built on a belief that suicide deaths among patients receiving care can be prevented. The key components include universal screening built into routine visits in both primary care and mental health settings, structured risk assessment, including the use of the Columbia Suicide Severity Rating Scale to access risk more deeply. Um, Safety planning by creating personalized safety plans and limiting lethal means. System-wide integration to emergency departments and primary care, creating a broader safety net. Care transitions and that special attention is given to patients transitioning out of hospital or intensive care, which are times of heightened vulnerability. And we analyze the data and research to refine practices and improve outcomes across the system. And healthcare providers can make a difference. For all ages, including adults, 30% of suicide deaths are preceded by a healthcare visit within 7 days, and 50% of suicide deaths within the preceding 30 days. So there's clearly an opportunity for healthcare providers to work together to identify high-risk patients, connect them to care, and improve suicide outcomes. We see that in adults, at least post-COVID, US suicide rates continue to rise. I do have a future slide more about our youth suicide rates post-COVID towards the end of this presentation as well. There has been research from the Kaiser Permanente's Division of Research on Suicide Prevention and the Zero Suicide Model. A 2021 study evaluated the implementation of the Zero Suicide Model in large healthcare systems to understand how systems adopt and operationalize best practices. And they did see a reduction in suicide among patients. KP researchers also partnered with the National Institute of Mental Health and the Mental Health Research Network to study the fidelity and outcomes of the Zero Suicide Model implementation. And that research has shown positive results from the Kaiser Permanente's implementation of the Zero Suicide Model. A study this year in 2025, published in the Journal of the American Medical Association, or JAMA, analyzed data from over 300,000 patients and found that adopting the Zero Suicide Framework reduced suicide attempts by as much as 25% in participating health systems. And for systems that have implemented the model prior to the observation period, low and declining suicide rates were sustained. The role of technology is being used well. My healthcare organization utilizes its electronic health record system to enhance the Zero Suicide program. Our electronic health record system is used to support clinical pathways, automate screenings, and alert providers of potential suicide risks. And predictive analytics and machine learning are also being explored to help identify patients at higher risk. And just to add, this is my why. I met my childhood friend Todd at a kindergarten tennis camp. He was magnetic. He was charismatic, a gifted athlete, and somehow able to charm even the most disapproving teacher. We bonded over our shared love of drawing, and I still remember a get well card that he made for me when I was sick, featuring an incredible sketch of Snoopy and the Peanuts gang. It was kind of the thing that only Todd could do, being thoughtful, creative, and just full of life. As we grew older, our paths drifted. We had different classes, different social circles, but the friendship we shared in those early years were deeply formative for me. Then in my junior year of high school, Todd did die by suicide. His death marked the beginning of what we now recognize as a suicide cluster, though at the time we didn't have that language for it. The impact of our school and community was devastating. It ruptured something in all of us, and it's still something I still mourn. Uh, Todd's story is part of why I do this work, and it's why I believe in prevention and compassionate care and in the power of safe, informed conversations. And because every life matters and every loss leaves a lasting imprint. When it comes to suicide prevention, using structured, evidence-based practices can make a life-saving difference. Many patients seeking mental health care are vulnerable to suicide risk, and a suicide risk assessment provides a reliable clinical framework to help identify those at risk and connect them to the care they need. One powerful tool we use is the Stanley Brown Safety Plan. It's a collaborative intervention that helps high-risk patients manage crisis. These plans have been shown to save lives by giving individuals a clear, personalized strategy when they're in distress. I'll show you more in that in detail in a future slide. In integrated systems of care, like Kaiser Permanente, every provider plays a role in suicide prevention. That means every visit is an opportunity to check in, assess risk, and ensure no vulnerable patient slips through the cracks. Again, structured assessments and safety planning aren't just helpful, they are backed by research and proven to reduce suicide risk. These practices are reviewed during even sentinel case reviews to ensure quality and consistency in care. One of the most widely used tools in suicide prevention is the Columbia Suicide Severity Rating Scale, or CSSRS. It includes both a screening component to quickly assess suicidal risk and a risk assessment component for deeper evaluation. In a universal screening setting, healthcare providers begin with two simple questions. Number one, have you wished you were dead or wished you could go to sleep and not wake up? This screens for passive suicidal thoughts. And number two, have you actually had any thoughts about killing yourself? This identifies active suicidal thinking. These two questions take just 20 to 30 seconds to ask. If someone answers yes to the second question, the screening expands to 4 additional questions that assess plan, intent, and behavior. To assess plan, the question is, have you thought about how you might do this? For intent, providers ask, have you had any intention of acting on these thoughts? And have you worked out the details of how to kill yourself? Do you intend to carry out this plan? And finally, to assess behavior, the question is, have you done anything, started to do anything, or prepared to do anything to end your life? Endorsing any of these additional questions may indicate a much higher risk for suicide. This screening is recommended for all patients aged 12 and older for providers to do across all demographics. It's a fast, effective way to identify those at risk and connect them to the care they need. The safety plan stands for Suicide Assessment 5-Step Evaluation and Triage. It's a structured approach used by clinicians to assess and manage suicide risk. It's designed to guide decision-making and ensure that individuals at risk receive appropriate care. There's 5 steps. Step number 1, identify risk factors. These are the characteristics or circumstances that increase the likelihood of suicide. I mentioned those in slides earlier. The goal is to recognize which ones can be modified to reduce risk. Step number 2, identify protective factors. These are the strengths and supports that can buffer against suicide risk. Enhancing these factors like family support, coping skills, or access to care can be a powerful part of prevention. Step number 3, conduct a suicide inquiry. This involves asking about the suicidal thoughts, plans, behaviors, and intent. That's like the Columbia Suicide Severity Scale. It's important to explore both passive and active ideation, as well as any history of attempts. Step number 4, determine risk level and appropriate intervention. Based on information gathered, clinicians assess the level of risk, low, moderate, or high, and select interventions that match the severity. This could include safety planning, hospitalization, or outpatient support. And then lastly, step 5 for providers is to document. Final step is thorough documentation of assessment, rationale, chosen interventions, and plans for follow-up. This ensures continuity of care and accountability. The safety model is supported by SAMHSA, draws guidelines developed by the American Psychiatric Association. It's a widely accepted framework used in both adult and youth populations. Let's take a moment to talk about safety plans, which are a vital tool in suicide prevention. A safety plan is a prioritized written list of coping strategies and sources of support that a patient can use during or just before a suicidal crisis. It's designed to be brief, easy to read, and written in the patient's own words, making it personal and practical. Safety planning is not just a checklist, it's a collaborative intervention between the clinician and the patient. It helps the patient feel supportive and gives them a concrete plan to follow when they're in distress. And so when should a safety plan be completed? It's clinically indicated anytime suicide risk is considered high, and a clinician can complete that safety plan during an appointment. The Stanley Brown Safety Plan is a structured collaborative tool, and it's used to help individuals manage suicidal thoughts and stay safe during a crisis. It consists of 8 key components, each designed to guide someone through a step-by-step process of self-care and support. Step number 1 is warning signs. This first step is identifying personal warning signs, thoughts, feelings, or behaviors that signal a crisis may be developing. Step number 2, internal coping strategies. These are techniques the individual can use on their own to manage distress, such as breathing exercises, journaling, drawing, or listening to music. Step number 3, people and social settings. This involves identifying safe places and people who can provide distraction or comfort, like friends, family, or community spaces. Step number 4, people to ask for help. Here, the individual lists specific people they can reach out to when they need direct support. Step number 5, professionals and agencies. This includes contact information for mental health providers, crisis lines, and emergency services. Step number 6 is making my environment safe. The plan outlines steps to reduce access to potentially harmful items or situations, like removing medications or securing firearms. Step number 7 is reasons to live. This is a very powerful step, and it encourages the individual to reflect on personal motivations for staying alive, family, goals, passions, or future plans. And finally, step number 8, what should my support team do? This plan includes guidance for loved ones or caregivers on how to help during a crisis. And so in summary, the safety plan is meant to be a personalized written document in the individual's own words and developed collaboratively with a clinician. This is what a safety plan template looks like when used as a form. It's a living document saved in the patient's health record and designed to be updated over time as their needs and circumstances evolve. We often talk about being prepared for emergencies like wildfires or natural disasters, but having a plan in place for suicide prevention is just as critical. It's really about being proactive, thoughtful, and ready to support someone through a crisis before it happens. Now I want to talk about restricting potential lethal means. Um, Research shows that having a gun or weapon in the home increases the risk of dying by suicide. 60% of all US deaths, suicide deaths, are due to firearms, and firearms used in youth suicide usually belong to a parent. Guns should be stored unloaded in a locked safe. Bullets should also be locked, but in a separate place. Gun safe keys or combinations to the lock should be kept only by the adults in the house. And consider purchasing trigger locks for guns. We at Kaiser Permanente have gun locks available in our pediatrics emergency department and psychiatry departments. In addition, if you're aware of your child having concerns of safety, you may need to lock away knives, razor blades, or other sharps from children and teens. And parents and caregivers should be in charge of the medications that are kept in the home. Keep all medications, both prescribed and over the counter, in a locked box if there's concerns about suicide. An adult should hand out and control all prescribed and over-the-counter medications to children and adolescents. Keep track of all bottles or medications as well as the number of pills in each container. And that includes all prescribed over-the-counter medications, as well as even medications used for pets in the home. Use pill boxes to limit quantities, and dispose all expired or no longer used medications by bringing them to your local pharmacy or drop-off location. If substances that can be abused are kept in the home, they should be monitored and locked. You should keep track of bottles of alcohol and lock them away. It's not enough to put these like out of reach. People can get to them. If marijuana is kept in the home, lock all forms of it in a lock box. And talk to parents of your child's friends about how they store alcohol or marijuana in the home. You may want to lock all toxic household cleaners, pesticides, or industrial chemicals away, or consider limiting ropes, electrical wire, or long cords within the home, or lock those away. And then finally, if this is indicative of in your situation, you may need to secure and lock high-level windows or access to rooftops. There are so many resources online, but there's 3 here that I really want to recommend and consider for further help and involvement. The first is the 988 Suicide and Crisis Lifeline. It's a free, confidential, 24/7 support line for anyone experiencing emotional distress, suicidal thoughts, or mental health or substance use crises. You can call, text, or chat by simply dialing 988. No need to remember a long number. It helps individuals in crisis, concerned family members and friends. Services are available in multiple languages and accessible for deaf and hard of hearing communities. It's a national lifeline that connects people to trained counselors who provide compassionate, judgment-free support. And it's a critical tool in suicide prevention. The second is the local San Mateo chapter of the National Alliance on Mental Illness. It's another fantastic resource. San Mateo is actually the original location and birthplace of NAMI. It offers free support groups, education programs, advocacy for individuals and families affected by mental illness. Provides support groups for youth, parents, caregivers, educational programs like peer-to-peer and family-to-family, crisis resources and referrals as well. NAMI San Mateo partners with law enforcement and schools to improve mental health crisis response and reduce stigma. And lastly, youth.gov, that's a federal resource hub offering evidence-based strategies, data, tools to prevent youth suicide. They have the information on risk factors and warning signs. They also provide guidance for schools, families, and communities to build resilience and protective factors. It also has links to national strategies and publications from the SAMHSA Substance Abuse Mental Health Services and the CDC. Now, on July 17th of this year, SAMHSA officially terminated the 988 Suicide and Crisis Lifelines LGBTQ plus Youth Specialized Services program. While one in crisis can still reach out to 988, there's no option 3 or text pride or connect with a counselor specifically trained in supporting LGBTQ plus youth or people under the age of 25 anymore. This is to say, at the very least, devastating. It's provided 1.5 million LGBTQ plus youth with suicide prevention services. And it's disheartening to see that this is kind of a politically charged decision that will have consequences to the health and well-being of so many. But I do want to say, consider the Trevor Project's free and confidential crisis services that are 24/7. There have been a lot of recent headlines to talk about, actually. Um, as AI chatbots become more common, concerns are growing about the impact on mental health, and especially among teens. A recent PBS News report highlights a troubling phenomenon called AI psychosis, where individuals develop distorted or delusional thoughts after prolonged interactions with AI chatbots like ChatGPT. One tragic case involves a 16-year-old whose parents filed a wrongful death lawsuit against OpenAI, claiming the chatbot discussed methods of suicide after their son expressed suicidal thoughts. While this is one of the first lawsuits of its kind, experts are saying that it reflects a broader issue. Some users, especially those with pre-existing mental health conditions, may experience worsened symptoms due to excessive chatbot use. AI psychosis isn't an official diagnosis, but it involves delusional thinking, believing the chatbot is superhuman or godlike, and chatbots and using them for hours on end or placing too much trust in AI are key risk factors. Another PBS investigation found that ChatGPT sometimes gave dangerous advice to researchers posing as vulnerable teens. Um, in over half of the 1,200 test interactions, the chatbot provided detailed plans for drug use, extreme dieting, and even suicide notes. While ChatGPT is designed to offer crisis resources, researchers were able to bypass safety features by framing harmful questions as academic or hypothetical. So this raises serious questions about AI safety, especially for young users. Teens often view chatbots as trusted companions. Many use them regularly for advice and emotional support. But experts do warn that AI is not a substitute for human connection or professional care. Uh, the responsibility lies with both tech companies and users. Companies must improve safeguards, and users, especially parents and educators, must monitor how these tools are used. The takeaway from this is that AI chatbots can be helpful, but they're not risk-free. Now, the topic of social media. Nearly 97% of adolescents use at least one social media platform. And while it offers outlets for connection, creativity, and support, growing evidence is suggesting it may also contribute to some rising rates of depression and suicide among youth. A recent study at UC San Francisco, published in JAMA Network Open, followed nearly 12,000 children ages 9 to 13. And over 3 years, these 9 to 13-year-olds had an average daily social media use that rose from 7 minutes to 73 minutes. And during the same period of time of usage, depressive symptoms increased by 35%. Importantly, the study found that increased social media use predicted more depression, but not the other way around. So in other words, it wasn't that depressed kids were spending more time online. It was that more time online was linked to worsening mental health. And so why? Um, while the exact reasons aren't fully understood, prior research points to risks like cyberbullying, disrupted sleep, and social comparison. Um, the impact of cyberbullying is especially alarming. 1 year after being cyberbullied, 11 to 12-year-olds were 2.6 times more likely to report suicidal thoughts, and 2.3 times more likely to experiment with substances, especially marijuana, nicotine, and alcohol. Um, these findings highlight an urgent need for digital boundaries, mental health education, and support systems that help kids navigate online spaces safely. I really want to stress social media isn't inherently harmful, but how it's used, how much it's used matters deeply. Now, there's some hope. I don't want everything to be doom and gloom. Um, Teen suicide is on the decline. Recent federal data in August of this year, literally last month, from the National Survey on Drug Use and Health, brings this hopeful update that rates of depression and suicidal thoughts among teens are declining. Um, Post-pandemic, kind of between 2021 to 2024, the percentage of adolescents aged 12 to 17 who reported serious thoughts of suicide dropped from 12.9% to 10.1%. Suicide attempts also declined from 3.6 to 2.7%. And the number of teens experiencing a major depressive episode fell from 20.8% to 15.4%. It seems like looking at it, experts are thinking the progress is partly due to increased access to treatment, especially care that's specifically designed for suicide prevention. More youth are being screened, supported, and connected to services that address their unique needs. One note though, the report didn't break down data by race or ethnicity, which limits some of our understanding of how different communities are affected. But in summary, we're seeing signs of hope. We just really do need to continue to invest in prevention, treatment, and inclusive data to ensure every young person gets the support they need. It does seem, though, that we're moving in the right direction. Oh, and so these are some of my references, but in closing, meaningful change in preventing youth suicide takes all of us, parents, educators, clinicians, and communities working together. We must normalize the conversation around mental health and ensure that care is accessible and stigma-free. Suffering should never be tied to shame, and suicide is preventable. We have the tools and resources to fight it, and we should fight it together. So thank you so much for being here today. I truly hope you found something valuable in this presentation. And I'll turn it over to Charlene maybe to help out to open it up for any questions you might have.
Well, thank you, Dr. Rex Huang. That was really a brilliant discussion of the subject. You can see from everybody's comments, the audience, we're all really here with you. And there's some important questions. So let's just dive right in, okay?
Sure.
I think this one is really important. Speaker asks, what harm does assuming that suicide can be prevented due to the friends and family left behind when an individual dies? We know that other diseases are treatable, but even then, not everyone survives. Upon death, we typically celebrate their fight against the disease. We don't typically live in shame and not talk about their passing, like often happens with death by suicide.
Yeah, I think there's every child and every adolescent will treat the news or the events of suicide differently. They will mourn and they will struggle and they will fight in different ways. And it will look differently for every person. I don't think that's easy to just you know, pigeonhole people in one category. And so people who experience, unfortunately, suicide or get exposed to that um, may have some risks, especially if they have pre-existing mental health conditions. But I think what's more important is how we screen and how we actually support and showcase the importance of how important it is to seek the care, to have the dialogues, to work through the pain that people might have, um, and to know and give the hope that there are things that we can do to help work on preventing suicide. Um, the because 90% of suicides have some tie to mental health disorders, the screening for that is very important. And I would say that being able to then identify that risk can open up, as I mentioned in some of this zero suicide model, open a structured risk assessment way that opens and understands the stratification of risk and gives us then the tools and opportunities to give the person the direction and the treatment that's appropriate for them.
All right, thank you, Dr. Huang. That's very helpful. So here's a question that I bet a lot of parents have. Um, the attendee asks, how are parents supposed to know whether their child is truly suicidal when they voice their ideations versus a child who may be being manipulative?
That's a great question. And it's hard. I think parents will often say that, oh, you're getting this for attention. Maybe there's certain behaviors before that were behaviors that might have sought attention. Um, that being said, the risk of suicide is kind of permanent. It's great. I think we really should err on the side of caution, first and foremost, and we give the emphasis and the message that life matters, and that if someone is in danger of that, that we take that seriously, and that we take those approaches and move forward in taking that seriously. Um, I think trying to understand, if there are um, people who say that they really didn't mean it, um, I think it's still important to take the time to dive in, that maybe there are other things that are going on that are the risk factors that still make it important for us to take that and take the steps and the necessary steps. Because when you weigh the pros and the cons, um, if you make the mistake and say, well, wow, they really were suicidal, the consequences too great, in my opinion.
Okay, so take it seriously. I mean, your statistics in the beginning about the chance of someone attempting again, that was pretty sobering.
That was. And I think that we, we do take into account that people who are recently hospitalized for suicidal thoughts or an attempt are at huge risk for having a repeated attempt or repeated suicide dangers um, immediately after leaving the hospital. We usually recommend intensive outpatient programs after a discharge from the hospital
Mm.
because it's that important. You need more eyes, you need more people involved, you need parental involvement, but having not just letting them go and hoping that it just goes away, that the problem goes away, that does not work.
So Dr. Wong, we have just a few minutes left, but this is a question that you touched on this earlier, but let me just give you a minute at it. The question is, do you have anything to add about youth with disabilities or social challenges and ways to promote for prevention or to look for signs that for kids that may be less verbal?
Mm, good question. I think that people, children and adolescents that are maybe not as verbal, it is much more difficult to see and predict that. You lose the verbal cues that I've mentioned, and so you really have to sort of base things on behaviors, and then really understanding some of what the root cause of some of the behaviors. And someone who might have developmental disabilities and are nonverbal, um, they may be hitting or hurting themselves. It may not be suicidal, it may be that they're actually sick. And they're showing that through self-harm behaviors or kind of aggression or a swift change in behaviors. So it is important to kind of tease out some of those things. And if you were ever concerned about a nonverbal child, then it may be helpful to check in with a provider and try to understand more or get some more eyes on the situation.
Okay. And again, sorry, these are tough questions, but we're just going for it here, Dr. Wong. Unfortunately, we're seeing this a lot. The parent asks, suicide can sometimes come with homicidal ideation. Is support similar to addressing homicide when it's part of suicide?
Oh, that's a good question. Um, I mean, um, when somebody is in danger of hurting others, that is also very severe. And that could be grounds for, if it's due to a mental health uh, condition, they may need to be stabilized in a safe place to assess the safety of others and themselves, and then treat any underlying mental health condition that might be involved with that. Um, it takes a lot of bravery and it takes a lot of um, steps to take a hard look at oneself. So if you have a child that you're really worried about the concerns of harm towards others, um, you know, sometimes the natural inkling is to try to be in denial and not want to deal with this and hope that this is just something that they'll grow out of. Um, Again, the consequences can be too great. And it's really important to understand that um, investing and sometimes taking these hard steps to seeking your child's care, and that may need to be where the child needs to be in a safe place, will be worth it. That step could really change the course of not only your own child's life, but so many others.
Absolutely. So, Dr. Wong, we've come to the end of our really important hour together. I'd like to ask if you have a final thought for the parents and caregivers and advocates on with us tonight.
I just want to say that there is hope. I just want to say that um, being parents, being educators, having these connections with your child or adolescent, it's such a blessing, and you probably are holding on to so much. I just want to give you the hope that, again, suffering should never be tied to shame. And if we can give our children and adolescents, our youth, the message and the modeling that our mental health is important. It's worth it. It's worth the investment. Um, Again, we can save lives. We have the power. You don't need to be a healthcare provider. You have the power to save lives. And I just am grateful that you taking the step to being here already is that first step.
Oh, thank you so much, Dr. Huang. That was the perfect way to end our conversation tonight. So a special thanks to Kaiser Permanente and to San Mateo County Health, and for all of you who help support this program, Sequoia Healthcare District. Take care, everyone. We will be providing a video of this event, and we hope you'll stay on for a couple of seconds to respond to our survey. But again, special thanks to you, Dr. Rex Huang, for a really important presentation tonight. Take care, everybody. We hope to see you again soon. Good night.